Welcome to Health Focus, where we focus on your health. I'm your host, Dr. Scott Anderson, and we're focusing on pain management, preventing pain if possible, and what we could do to help people who are suffering from acute or chronic pain. And we have an excellent guest for that, Dr. Marko Bodor. Welcome to the studio, Dr. Bodor.
Thank you, Scott.
And Marko, I know that you've had a distinguished past. You're a physical medicine and rehabilitation doctor. You've been affiliated with the clinical faculty at UC Davis, at UCSF, in physical medicine and rehabilitation, and I believe in a neurosurgery department. And so would it be best to say that you're primarily a physical medicine and rehabilitation doctor?
That's correct. I'm a physical medicine and rehabilitation doctor. I'm subspecialty board certified also in sports medicine and also in pain medicine. And I'm a fellow of the American Institute of Ultrasound and Medicine and electrodiagnostic medicine, which is where you use a computer to analyze nerve signals. So all those things. I'm a jack of all trades, like a Swiss Army knife.
Quite impressive, and I believe you have a book right off the press that probably is not so much for the general public, but is highly regarded among physicians, Atlas of Interventional Orthopedic Procedures, and you're one of the editors, I believe.
Yes, that's correct. I'm one of the editors. Just came out a few months ago.
And you're in practice near what used to be called Queen of the Valley Hospital, but it's now called Providence, I believe, St. Joseph Providence?
Correct. Providence, St. Joseph, yes.
Up in Napa.
I've been there for 28 years.
Okay. So let's get into the issue of pain. Now, as a rheumatologist, I sometimes think, well, pain is not as useful a concept as a precise diagnosis. But nonetheless, pain is something that's been with humanity for millennia, right?
That's correct. You know, in writing one of my papers, I was wondering, what is the real reason we have pain? Because most of my colleagues who are pain specialists at Stanford and UCSF, they think of it as a nuisance. Pain is always bad. And then when you look at it from that perspective, you may not actually be able to get rid of it. So you have to ask yourself, why do we have pain? What is the real reason we have pain? And everyone can chime in here, but I thought of three reasons. The first reason we have pain is to avoid, is to alert you to a potential intrusion by an insect. Let's say you're out having a nice evening in the outside and you feel a little something. You take a look, there's a mosquito there, and you go, swat, you got him. And the second reason we may have pain is to avoid doing something stupid. So if you have a couple of teenage boys and they're trying to show off and they're going to jump off a rock with their bike or something, well, when they fall, they realize it hurts and they're going to think twice before jumping off a bigger rock. So the second reason we have pain is to avoid harm. The third reason we have pain is one that's more elusive than people don't think of it. The third reason we have pain is to help us, guide us to optimum internal and external, to the optimum internal and external environment for healing. So we have evidence from 10,000 years ago that primitive men were able to splint fractures. And they never went to medical school, they never read a book, but they knew that if they held their hand to the fractured arm, that it felt better. So they couldn't walk around all day holding their hand there, right? So they put some sticks and they wrapped it with some leather and twine, and they created splints, and it felt better right away. So the purpose of the pain is to guide the organism, a human, to doing something like this, or an animal to walking on 3 legs, and then at 1 month, when the fracture heals, then they know to go on 4 legs, maybe 3-4, 3-4, if you've ever seen a dog with a broken leg. So those are the 3 reasons why we have pain, and we have to think about those reasons when we treat acute pain, because there's some new interesting information about the transition from acute to chronic pain that you might be surprised about.
If I may chime in, as you say, regarding this, I think I agree completely, and also we have some diagnoses that indicate the usefulness of pain to some extent. One is the concept of a neuropathic joint, where in diabetes or with some infections, we don't feel pain from the joint and we inadvertently damage the joint. And in fact, there's a rare medical condition that has been called congenital indifference to pain. And some people who just don't react to pain also end up injuring themselves.
Absolutely.
And I think, for example, many of us have the experience as we get older of going from, say, jogging on concrete or asphalt to doing something low impact. And part of that is our knees telling us, gee, I'm feeling a little pain, maybe I should reconsider how I exercise. So I totally agree. I don't think pain is completely a bad thing. But when does it become a bad thing? I mean, I have my own thoughts, but what's your perspective?
Well, it's definitely a bad thing when you mention neuropathic pain. Pain doesn't serve a purpose. If you have an injured nerve, let's say from an amputation, from a trauma, from a car accident. I have a patient who lost a finger from a shark attack, and another patient who lost a finger from a pit bull biting it off, and they have pain where the nerve was severed, and that's neuropathic pain. And that pain just is the nerve firing, and it served no purpose. So that's when the pain is not useful, is when it's a neuropathic pain, it's a pain that's not useful. Or potentially pain that is from a terminal disease like cancer, where the pain is invading the nerves, and it's invading some areas, and you get those warning lights are on, but there's nobody can fix it. You may have already done chemotherapy, you may have already had surgery or radiation. At that point, that pain is not really serving a purpose. But for acute pain, it's very interesting. A paper came out last year, and my patients alerted me to it because it was covered in the New York Times. A paper came out last year in Science and Translational Medicine, and it was entitled, I won't actually give you the answer, I won't give you the spoiler. What a group of researchers did in Montreal was they took rats and they injured their tails, which is an extension of the spine. The tail is an extension of the spine. And they wanted to show that treating that acute pain was going to prevent chronic pain from occurring. And so they gave them nonsteroidals, and they gave the controls just a placebo. And they expected that the rats that got the nonsteroidals for acute pain were less likely to have that pain ingrained in their brain and go on forever. But it turned out to be the opposite. The rats that got the nonsteroidals were more likely to have chronic pain 3 weeks and 6 weeks later than the ones who did not get any, who just got a placebo. And they also found that there are about 500 genes that are upregulated when you get that acute pain. And those genes are, they actually identified the genes. And then they looked at the United Kingdom Biobank, and they looked at people who took pain medication for their acute pain versus who didn't. And the ones who took nonsteroidals, that means Advil or Motrin, were more likely to have chronic pain 6 weeks later than the ones who took Tylenol, for instance. So there's a reason why we have that pain. It's to guard you, to protect you, and then there are all these genes that are upregulated, and that leads to a very robust healing response. So it's paradoxical, but if you really have to, when you get an acute injury, you have to listen to the pain. You have to take it easy, slow down, see a doctor, and protect that joint, protect the area that's been injured. Don't just take nonsteroidals and keep going, because that looks like it's the wrong answer.
Right, and we know that some medications can paradoxically cause pain even though they're analgesics, as you pointed out. Ibuprofen or Motrin has been associated with headache pain. There can be an ibuprofen-induced headache syndrome. And I believe there's also an opioid-induced hyperalgesia where you feel more pain. So what you're saying strikes me as being completely right on. Let's talk a little bit more about chronic pain. Now, as a rheumatologist, of course, I treat arthritis. I know that you particularly, as a physical medicine and rehabilitation doctor, I understand you treat just about everything causing pain, but I know that you have an interest in the spine. So let's talk about spinal pain. It's a common cause of visits to doctors, isn't it?
Yes, absolutely. Well, you know, we look at quality of life and pain around the world, and there is a big study called the Global Burden of Disease Study. And every year they publish about 10 papers looking at what are the most prominent problems affecting humanity worldwide, the ones that are causing the greatest loss of quality of life. And number one worldwide is low back pain, worldwide. And in every state in the United States, low back pain is number one, except in 4 states. And in those 4 states, that would be West Virginia, Kentucky, and Tennessee, and one other state. The number one cause of years lost to disability is not low back pain, but it's opioid use. And but those 2 things are actually interrelated in a way.
Right.
So the number one cause of low back pain, chronic low back pain, we like to divide it up into different parts of the back. But the number one cause is a degenerating disc in young people. The number 2 cause can be the facet joint. The number 3 cause can be pinched nerves. But before you would actually get into treating those things, you want to try to prevent those things. And you prevent those things by getting enough sleep, by exercising, by having a good diet, and paying attention that when you get a little injury, when you get a pain, don't think it's the end of the world. but take it easy for a few days, but keep going. And as of the most recent data, I would not take any anti-inflammatories for it. I would maybe take Tylenol, but I would not take anything.
And I know that you have a background, as well as being a physician, as someone who has studied biological anthropology, in fact, at Harvard University, as I recall. And I think it brings to mind the evolutionary burden of having bipedal posture, meaning walking on two legs. We have the spinal column that really evolved back after the age of the dinosaurs, largely in animals that have four limbs that they walk on. And then the modern descendants of the apes and so forth, the hominoids, you might say, the hominids for humans, or hominins as some say, are bipedal, and that's really hard on our low back because we have this vertical weight on a narrow column. So we're kind of at risk. I mean, low back pain is pretty much ubiquitous. Almost everyone gets it eventually.
Yeah, it's all over the world. It's in China, it's in every country. Low back pain is number one, right, except in those certain states of the United States where low back pain maybe has led to opioid use and so on. But it is number one for the reasons you mentioned, but also because of inactivity. I think that inactivity can also paradoxically cause that to be worse, because people sit for a long time behind the steering wheel of a car or at a desk, and those things are not good for the disc. You want to have off and on loads are healthy, whereas just a static load can be bad. It's very important to change posture. When you're sitting, working, it's important to shift your weight, to change, to lean forward. Don't be stuck in one position all day. Even the proper posture, if you're just stuck in that position, eventually your muscles are going to get tight and whatever. The ones who have the least amount of pain are the teenagers who slouch and they twist, but every moment they're shifting.
Right.
And so they're always offloading. And so that's probably the best posture. And the Scandinavians, when they developed their ergonomic chairs, they're different than our chairs. Their chairs are designed with little places for your feet to go on top of the feet of the chair, so that you can constantly use your legs to push your spine this way or that way. You can power and you can crank
right.
your leg up this way or that way, rather than being stuck in one position.
Right, we didn't evolve to sit at a desk all day.
No.
Let's move on to the next, shall we? I believe you brought in a model.
Oh yeah, absolutely. So I mentioned the number one cause of chronic disability in the world is the low back, but the neck is number 4. The knees and the hips are number 2, but the neck is right here. And the number 1 cause of chronic neck pain are these little joints called the facet joints. You see those little diagonal little cracks in there? Those are often injured in car accidents, whiplash injury. And there are little ligaments around here that are injured. And we have in the past injected them with steroids using X-ray, and that doesn't really help. So what the treatment is for terminal pain, if it doesn't get better over time, is an ablation. That means you ablate the nerve endings on either end with microwaves. That's a very invasive and treatment that has to be repeated every 18 months. But we've been using our own body's cells, platelets, which come in our bloodstream, and they are able to enhance natural healing. Because we know that some people get injured and they heal, and some people get injured and they don't heal. Everybody heals a skin lesion. For instance, even you can be 100 years old and you cut yourself, you're going to heal. But there's some things that nobody's going to heal, like a spinal cord injury. Nobody's going to heal that. But there are a lot of things that are in between. Discs, facet joints, the anterior cruciate ligament in the knee, those are things that can heal in some people, but not in all people. But we can enhance it by injecting the platelets, which are part of your blood's healing. And we use 3-dimensional imaging, not 2-dimensional like is commonly used, and that's with ultrasound, to approach these very precisely. And that was a paper we published last year, and it was in the top 10 articles in Spine Journal last year.
That's very intriguing, and I know you have a lot of experience in publication in this area. Of course, the history of medicine, Marko, it's filled with ideas that make perfect sense that just don't pan out when they're subjected to rigorous prospective double-blind trials. So I just want to ask kind of a question that's deliberately a bit provocative in terms of questioning that. You pointed out physiologically why this should help, but has anyone demonstrated that these injections actually work better than, say, sham injections? Has this been demonstrated in a prospective, blinded manner?
Yes. That's a great question because these injections are being overused. There are many clinics are popping up because they're cash pay, and many people will have a fancy office with a fancy waiting room, and the techniques that they use are not great, and the equipment that they use is very inexpensive, but they have very expensive sofas and so on. Those clinics are doing all kinds of things, and they're not evidence-based. But there are, these studies have been subjected to rigorous randomized controlled trials. And as a matter of fact, my colleagues at UCSF published a paper, I have it right here.
Okay.
This is for knee arthritis, for instance. And they wrote, they looked at all the randomized controlled trials, and they found that for knee arthritis, it is effective. It's not a cure, but it's effective. And they found that they've actually identified a specific cost. And so this was published by Dr. Bendich, who was a resident, and then Dr. Feely and Dr. Lansdowne, who are both professors of orthopedics. So there are papers are coming out, and there was a paper last month on carpal tunnel, and it's effective for carpal tunnel. But for these facet joints that I just described, we don't have a randomized control trial. And that's something that we plan to do in the future.
So what you just described, Dr. Bodor, is that distinct from bone marrow injection with a PRP technique? Or
yeah, the bone marrow aspirate concentrate?
Yes, can you explain the difference?
Oh yeah, sure. Well, the PRP is from your bloodstream, where you draw blood, and we isolate the platelets, which are the fixer-upper cells in the bloodstream. Whereas the bone marrow cells are from the bone marrow, and we go into the bone and we aspirate them, and those cells are the source of platelets. So they're the source of all the blood elements. So the red blood cells, the white blood cells, the platelets, they all come from the bone marrow. So those cells there have not just those cells, but the factories that make the cells, which are some stem cells and some other cells. So that's a little bit of more of a richer mix, and that's a little more powerful. But I think that's also should be a last resort, not as a first resort.
I'm thinking about, for example, low back pain. Now, do you employ this also for low back pain?
Absolutely.
So if I may just make a comment.
Yeah.
If you look at all comers with low back pain, I recall this from the literature from a number of years ago, 80% of people will have their back pain resolve in 2 weeks, 90% in a month, and 93% in 6 months. But the 7% who have chronic pain consume half of the healthcare dollars dedicated to back pain.
Yes.
So I'm wondering if what you're describing would be something that would be geared towards a minority of people who don't get better with conservative treatment. Because frankly, it sounds pretty invasive, aspirating marrow from someone.
Yes. So I would use PRP as a first choice for the disc problem. So first of all, as you said—
Excuse me for interrupting. What does PRP stand for?
Platelet-rich plasma.
Okay.
But let's go back to that. You said about 7% might have the chronic pain. And people should try everything. They should give it time, sleep, rest, and so on. Only if it's gone on for a year or so would you consider one of these invasive treatments. So disc pain is a common cause of chronic back pain, and we have found that the PRP is effective. And there have been about a dozen randomized controlled trials and prospective trials, maybe 3 randomized controlled trials and about 3 prospective trials and some other observational studies that have shown that to be effective. So I'm still not 100% convinced. I've done over 1,000 disc injections. Our success rate's about 70%. Not everybody's a candidate. Only 1% of patients are a candidate for this.
Let's move on to a broader discussion of pain. Obviously, it's such a huge topic, but you mentioned lifestyle. You mentioned West Virginia. West Virginia also ranks very high in obesity and cigarette smoking. In fact, in terms of ranking of the nations, of the states, the Appalachian region is high in all of that. So lifestyle obviously is important. I think we agree about that. You also, though, can provide, I believe, surgery in selected cases, referring to your colleagues, but we try to avoid that, don't we, with back pain if we can?
Yes, absolutely. Surgery is indicated primarily for a pinched nerve. When the nerve is pinched and you're losing function, that's the main indication for surgery as a neurological impairment. For chronic pain, if it's disc pain, it should not be the first choice. That should be the last choice.
You also are involved in a new entity which you've called shoulder immune reaction, I believe. CIRVA, can you tell us about that?
CIRVA, yes, it's the most common disabling complication of a vaccination, any vaccination. So people might have heard rumors about this and that happening during our epidemic, but the number one complication of a vaccination, any vaccination, is shoulder injury related to vaccine administration. And that's where the vaccine doesn't go into the main muscle here, into the deltoid. It goes up into the rotator cuff. And so if the injector goes a little too high, the rotator cuff is located right underneath here. And you should always cover up the top of your deltoid with the 3 fingers or so to make sure that they don't inject up there. But if it goes into the rotator cuff, it can cause chronic inflammation, and that goes on for years. It's a rare complication. It's about 1 out of 10,000 to 1 out of 100,000 vaccinations. So we don't have to really be that worried about it, but it is there. And for those who do get it, it can be very disabling and cause chronic pain.
So I think you would agree, though, that the benefits of vaccination are so enormous in most diseases that we would not attempt to talk somebody out of a vaccine out of concern for this relatively uncommon.
Absolutely not. Absolutely not. I'm pro vaccines, and you just have to inject into the fat part right here into the deltoid muscle. So that is something that I discovered. I'm very proud of it, and it's been referenced by over 100 papers around the world since I discovered it.
And just quickly, how do you treat it?
In the beginning, you can get some cortisone shots. This is one area where cortisone works very well because it's an autoimmune problem. It's where the vaccine is causing the immune system, the white cells, to go in and infiltrate and attack the actual, so cortisone shots.
And the complete name of the syndrome again?
SIRVA, S-I-R-V-A, shoulder injury related to vaccine administration, SIRVA.
Okay, so we want to give those injections in the right location. Now, you also treat some issues that are not purely pain-related but functional, but can lead to pain, like Dupuytren's contractures. That's when the hand contracts. There are some products advertised for that break down collagen.
Yeah.
Do you use those? Do they help?
Yes, they are helpful. Dupuytren's is a disease that causes the fingers to be stuck like this. Not to be confused with trigger finger, which can also cause the fingers to be stuck, but and it causes nodules in the palm. And this Xiaflex, it was actually invented here in the Bay Area. It's very expensive. It's about $5,000 per shot. And yes, I do inject that, and I use ultrasound guidance so we can precisely see exactly where we're going to inject. And you can gain anywhere from 50 to 80% restoration of movement for that.
And I believe also you treat carpal tunnel syndrome. And
Yes,
again,
yes,
carpal tunnel syndrome it's primarily a neurological impairment, but it certainly can be associated with lancinating pain into the fingers in some people. I believe you brought some instruments.
Yes,
Can you show them to us?
Yes, yes. So here in the Bay Area, we developed a technique using this little instrument. This was developed by the late Fletcher Eister. He's a neurosurgeon, and Bruce McCormack, who's a neurosurgeon at Cal Pacific, and Greg Bunke, who's a plastic surgeon. And they developed this to be passed right through the tunnel like this, and a little saw comes out, then this little sharp comes out through the palm. Of course, you're all numbed up, and you can saw through the ligament, then this gets retracted, and then it comes out, and you just have a little tiny incision, which is just 2 millimeters or so. And that was developed in 2013, and we were doing that quite a bit. And then my colleagues at Mayo Clinic developed this device, which has a little blade. It's a little bigger, but it's just as effective, and I think it's actually smoother. So with these operations, you can use your hand within 2 days after a carpal tunnel release.
And of course, you want to see your primary care. You want to make sure that there are not conservative modalities that could be employed. Do you have anything to offer to individuals with sort of non-specific pain in soft tissues, for example, fibromyalgia?
Yes, I used to treat fibromyalgia years ago, and honestly, I'm not an expert on that anymore. I would just recommend seeing somebody who is and getting plenty of sleep and light, gentle exercise. And I have colleagues who are experts. Melissa Meacham in Mill Valley is an expert on that.
I agree 100%. Our time is growing short, Dr. Bodor, but I would just like in the couple minutes we have left to ask you, what do you see developing in the future of pain management?
Well, in the future, I'm dedicated to looking at people, not just treating them all with the same approach, just treating the pain itself. I'm looking, first of all, to find specific locations where the pain's coming from. I want to find exactly to the millimeter where the pain is coming from. And with more advanced imaging, we'll be able to figure that out. And we also have new ablation techniques which can ablate nerve endings that are causing pain that are not, that's not useful. And so we're developing those new ablation techniques for chronic pain that doesn't have a cure. But otherwise, I'm looking for cures for the things that we don't have cures for.
Right. And I think it's important to point out that pain is not a precise diagnosis. And everything people do to maintain their health, such as cancer screening, colonoscopy, pap smears, now there are recommendations for CT scans for chronic smokers to rule out lung cancer. None of that becomes any less important because we're talking about the management of pain. We still want to tailor the treatment to the individual patient. Would you agree with that? And,
Absolutely.
And managing pain requires being a good doctor overall.
Absolutely.
And obviously you have tremendous experience and credentials in this respect. As our time begins to wind down, how could people get in touch with you? Does your practice have a website?
Yes, it's Bodor Clinic, B-O-D-O-R Clinic. You can just Google it and you'll find our website.
And sort of closing advice, I think, you know, we're kind of in agreement that things like being in good condition, not smoking, exercising, changing your position, not straining your joints, those are things we can all do to help prevent pain.
And I would also say, if you're middle-aged, don't go and take anti-inflammatories and play tennis. That's the way we used to do it in the 70s.
Right.
You should see a physical therapist or a physical medicine and rehab specialist or orthopedist or rheumatologist,
Right.
get a proper diagnosis, and then figure out what's really causing the pain and try to find another way to treat it. Don't just take those pills and play on them.
Right. As a rheumatologist, I completely agree, but I really love your perspective from your view of this as a physical medicine and rehabilitation doctor. Thank you so much for joining us on this set.
My pleasure.
And I hope we can continue this conversation.
I would love to.
Dr. Marko Bodor, it's been a great honor to have you here.
Thank you.
Remember, here at Health Focus, we focus on your health. We've tried to focus today on pain management. Try to do everything you can to stay healthy, and we look forward to seeing you back again in the future. Have a great rest of the month.